Good evening, everyone, and welcome to our course, Principles of Surgery. Today, we will be discussing management of diseases of the stomach, and it's my pleasure to introduce you our speaker today, Dr. Stanley Ashley. Dr. Ashley is the Frank Sawyer Professor of Surgery at Harvard Medical School and surgical oncologist in the Division of General and Gastrointestinal Surgery at Brigham and Women's Hospital in Boston. Thank you, Dr. Ashley, for joining us, and we are looking forward to your presentation.
It's an honor to be here. This is a relatively broad topic, and I tried to cone it down in a few areas. GI bleeding, peptic ulcer, gastric neoplasms, and then a little bit at the end, if we have time, on post-gastrectomy syndromes. Each of these I could probably talk for more than an hour, but I tried to reduce the verbiage. So first, upper gastrointestinal bleeding. In the US, still a huge problem. That aspirin tablet is one of the reasons we have not controlled this completely. About 300,000 hospitalizations a year in the United States. And then another 50% additional episodes of bleeding in patients who are hospitalized for other reasons. It still has a mortality rate of up to 14% in the US. The reality is that 80% stop spontaneously before we do anything, but a significant percentage of those rebleed, and the main therapy is endoscopic. Core principles in managing upper GI bleeding. The first part is assessing hemodynamic status and resuscitating. Then we want to determine the source of the bleeding, intervene to stop active bleeding, and then treat whatever's caused the bleeding and prevent recurrence. This is just a little chart on assessing the bleeding. Obviously, when somebody comes in, just like in trauma patients, the hemoglobin and hematocrit have not equilibrated and are not going to tell you much about how much the patient is bled. Usually, if their vital signs are completely normal or a little bit of tachycardia, they have not bled more than 10%. Then we see postural hypotension, and that suggests a 10 to 20%. Frank shock, 20 to 25% blood loss. So like in a trauma patient, you make some assessment of where they are hemodynamically. Virtually every patient should get 2 large bore IVs and begin resuscitation. And there are a number of scoring scales for stratifying how high the risk is. This is one that's commonly used. They get points for how high their BUN is, how low their hemoglobin is, their blood pressure, and their heart rate. And if the score's high enough, those patients we should be thinking about scoping relatively quickly. There's pretty good data that in most patients, you don't have to take them immediately to endoscopy. But within 24 hours, it decreases the length of stay, costs, the need for surgery, and mortality. Urgent, emergent endoscopy right away is when they're really bleeding a lot. Although More endoscopic therapy is associated with that kind of early endoscopy without a change in rebleeding rates, surgery, or mortality. Low-risk patients, very low-risk patients can even be discharged. But in those patients with a high score, early endoscopy is associated with improved outcomes. So first thing to think about is whether it's an upper GI bleed. Obviously, hematemesis is almost always going to be proximal to the ligament of Treitz. Melena is typically that way. If they're azotemic, if their BUN is up, that suggests absorption of nitrogen from blood in the small bowel and an upper GI bleed. It's always a question about whether to put down an NG tube. There's pretty good data that lavage with an NG tube is of not really any benefit. But if you put down a tube and you get some blood out, you can start looking for an upper GI bleed. It doesn't rule out a duodenal bleed, particularly if there's no bile in the aspirate. So then taking a history of things that are important, whether they're on Coumadin or other antithrombotics, non-steroidals, dysphagia might suggest a malignant source. If they've had weight loss, again, you worry about a malignancy. Obviously, a history of ulcer, liver disease, varices points you in that direction. Heavy alcohol consumption. And if they've had an aneurysm repair, thinking about an aortoduodenal fistula should be on your radar. Management before endoscopy. So PPIs, we usually start in everyone. There is pretty good data that if they have an ulcer, it reduces the need for treatment, i.e. there are fewer actively bleeding or visible vessels. There's no data to suggest that PPIs reduce the need for endoscopy, the mortality, or the need for surgery. Again, we mentioned NG lavage. It's really hard through an NG tube to adequately lavage, so it's not a benefit for that purpose. Prokinetic agents can be useful to empty the stomach, get the blood out before you do the endoscopy. As far as reversing antithrombotics, there's pretty good data that if the patient's INR is in the range of 1.3 to 1.6, there's no need to reverse things. We do just as well controlling things endoscopically. And then there's good data that a low threshold for transfusion is associated with better outcomes. This is a trial from the New England Journal that suggests a restrictive strategy, transfusing only for hemoglobins less than 7 was associated actually with better outcomes. So etiologies, depending on where you are and the number of patients with cirrhosis, variceal bleeding may be a higher percentage, but at least today in the US, peptic ulcer is responsible for 50% of upper GI bleeds, varices 30% overall, and then a long list of other things, esophagitis, Mallory-Weiss tears associated with vomiting, tumors sometimes, although tumors it's unusual to bleed massively, Dieulafoy's lesions, AVMs. Dieulafoy is a focused AVM, but you can also have more generalized gastric AVMs that is sometimes called watermelon stomach, aortoenteric fistula, hemobilia, or blood from the pancreas. So this is kind of the algorithm we usually use. Endoscopy for diagnosis and treatment, if appropriate, and 80 to 90% of those who get it, you get initial control, have permanent control. If there's rebleeding, today we go back to endoscopy. And of that group who've rebled after initial control, 60 to 75% achieve permanent control. Of that group, 25 to 50% will rebleed if they're treated a second time. And then the question is whether to go right to surgery or, if available, embolize the lesions. Principles of endoscopy: big bore scopes that you can pass various instruments to use to control things and can irrigate a lot. And irrigation, so you can see exactly what's happening, is a critical part of this. The need for treatment is then stratified based on how the ulcer looks. The right one is just a clean-based ulcer that if there's no evidence of bleeding, we don't typically treat. If there's a non-bleeding visible vessel, we treat those. So this is kind of rates of rebleeding and the need for surgery. Active bleeding, they're going to rebleed 55% of the time without some form of therapy, and they're going to need surgery a third of the time. A non-bleeding visible vessel, again, high incident. And then adherent clot has a pretty high incidence. So the recommendation is, if it's not actively bleeding, but you see the clot right there, to wash it off and treat if you see something to treat. Pigmented spots, the clean base ulcer that I showed you before, those don't need further treatment. Whole lot of therapies. I would say the most common thing at our hospital is to inject with epinephrine to first get control of the bleeding, and then a thermal method. But if it's big time, clips are really useful as well. There's good data that two things have a much better outcome using two different methods than just one. Big ulcers are likely to rebleed. If they're endoscopically bleeding actively, patients that were in the hospital for something else are more likely to rebleed. Hemodynamic instability, significant comorbidities, no PPI. So at this point, a PPI is really important. One treatment, monotherapy, posterior wall duodenal ulcers rebleed. So this kind of shows an algorithm for what you do after you've controlled active vessel, intense PPIs. That usually means intravenous clear liquids for 2 days, and they probably ought to stay in the hospital at least 3 days. And then kind of the need for each of these things is reduced with less serious ulcers. So they've rebled a second time. Then the question is embolization versus surgery. Nobody's ever done a randomized trial of this because there's often not radiology available to do the embolization. But the data would suggest that if you can embolize, it's a lower morbidity than surgery, it's a lower mortality, but a higher incidence of rebleeding. So I think it should be the first choice if it's available and the patient is not bleeding so much that they're going down the tubes. We'll talk about ulcers in a second. Just a couple other things. This is a Mallory Weiss tear up usually on the lesser curvature associated with vomiting. Both forms of treatment work well under those circumstances. Varices are a different issue. And here, usually the treatment of choice in the US is banding. And you can put a bander and a rubber band around the excoriated area, good at initial control. This is our algorithm. Octreotide, if we think they've got variceal bleeding, again, conservative blood volume resuscitation, and all patients ought to get some antibiotics. Proceed with endoscopy. We do ligation more often than sclerotherapy and continue the octreotide for 5 days. Bleeding, we band again. And if they rebleed or there's failure to control, the choice today usually is TIPS. When I trained, we had 10 different shunt operations that we did for active bleeding, but TIPS is, if it's available, has really solved most of those issues. And I don't think we've done a shunt at my hospital in 10 years. Antibiotics have clearly been shown to reduce the incidence of spontaneous bacterial peritonitis and are actually and nosocomial pneumonias, and they're associated with a reduction in rebleeding. And then just to think about aortoduodenal fistula, these are very difficult to manage, but if a patient has a big bleed and they've had a graft, it is something to think about. So I'm going to move on to peptic ulcer disease. That was kind of a whirlwind tour. We'll talk a little bit about more with bleeding ulcers and surgery for those. The concept of a balance between aggressive factors, acid and pepsin, and a whole lot of mucosal defense mechanisms is still very important. But today we've recognized that the vast majority of ulcers are related to H. pylori or nonsteroidals. A little greater percentage of nonsteroidals with gastric ulcer than with duodenal. And treating this has completely changed how we think about surgical management of ulcer disease. There are really 4 indications for operation: intractability, persistent painful ulcers. With treatment of H. pylori and efforts to reduce nonsteroidals, the percentage of those today is, I've done 1 intractable ulcer operation for a duodenal ulcer in the last 5 years. So really unusual. Now, intractable gastric ulcers, where we are worried about malignancy, that's another issue, and we do more of those when they won't heal. Gastric outlet obstruction is mostly an elective procedure, very unusual today, but we do see it. And then the 2 emergent operations, bleeding and perforation. So we're a little bit, things have evolved completely over the last 20 years with treatment of H. pylori. Then for everything, we tried to do something to reduce the risk of recurrence, a definitive ulcer operation. And the other consideration was that all those have long-term GI morbidity, so thinking about how you reduce those. But today, with treatment of H. pylori, at least few of our trainees get much experience with ulcer surgery. So it is it really is a question whether in an emergent setting, you ought to be trying to do a vagotomy and pyloroplasty or gastric resection because of their high risk and a lack of experience with doing them. So just to go through the various operations we do, truncal vagotomy, dividing both vagi just above the GI junction. You can, if you feel the esophagus, you can feel the bowstring there. What we typically do is take a little segment of each, send it for frozen section to confirm we've got nerve. The issue with that, and we'll talk about it further, is that the stomach won't empty in 30 to 40% of patients if you've done a truncal vagotomy. So they need some form of drainage procedure, either a pyloroplasty or a gastrojejunostomy. Selective vagotomy, so dividing the trunk of the vagus below the takeoff of the branch that goes to the liver and the small bowel. There was a lot of interest in probably the 50s and 60s in this country. Nobody really ever demonstrated that it was of significant benefit. And then the third operation that really got a lot of attention was parietal cell or highly selective vagotomy, dividing the fibers off the trunk of the vagus along the stomach, preserving those to the antrum so that they're not problems with emptying, but you've denervated the acid secreting portion of the stomach. We do so few of these today that hard to recommend doing that in an emergent setting. Just shows a pyloroplasty, longitudinally opening through the pylorus and closing transversely, opens that up and prevents problems with gastric emptying. It's also a good way of access for controlling duodenal ulcer bleeding. Then various resections, antrectomy and vagotomy, taking out the antrum, and cutting the vagus, removes about 2/3 of the stimulation to gastric acid secretion, and dramatically, it was really the best operation for duodenal ulcer that couldn't be controlled. Really unusual to do today. So subtotal gastrectomy as a means of resecting gastric ulcers primarily. This is a Billroth 1, just suturing to the end of the duodenum, a Billroth 2 to the side of the jejunum in the reconstruction. And then this is a total gastrectomy, pretty unusual to need to do for ulcer disease. We'll talk about a little more with high gastric ulcers. But typically, because of bad reflux esophagitis, we do a Roux-Y in that reconstruction so that bile and pancreatic secretions don't get into the esophagus. So intractability, again, very unusual today, but I think the two choices there for an elective operation are vagotomy and antrectomy versus highly selective or parietal cell vagotomy. Gastric ulcer, again, malignancy should be the major concern in resecting the ulcer if it hasn't healed in any other way. These are kind of the options with gastric ulcers. Simple excision if it's a bleeding ulcer. Antrectomy to include the ulcer. This is with a high ulcer, a tongue of stomach up around the ulcer, so you include it with the gastrectomy, but don't compromise the GE junction. The Kelly-Madlener procedure is something I've never done, but it's described for very high ulcers that you're really worried about compromising the GE junction. You wedge out the ulcer up here and then take the antrum. Subtotal gastrectomy probably is more commonly done. And this is the Senday's procedure, which is the reconstruction after that. So bleeding duodenal ulcers. Your first priority is to open the duodenum and oversew the ulcer. And we typically discuss using 3 sutures, one medially, where often the bleeding is coming from or in the ulcer bed, and then one proximally to get the proximal gastroduodenal as it goes into the ulcer bed, and one distally. And then the question is whether to do an acid secretion procedure. You have opened the duodenum. It's pretty simple to extend that across the pylorus and do a pyloroplasty, and then a truncal vagotomy with that. But in the hemodynamically unstable patient, you're going to treat for H. pylori or do something to reduce their nonsteroidals. Probably not if they've had previous ulcer therapy, thinking about a vagotomy and pyloroplasty. But there is controversy about this. I'll show you some data in a second. Bleeding gastric ulcer, excising the ulcer for sure. Maybe if you think the patient is not the worst risk or too hemodynamically unstable, thinking about gastrectomy to include the ulcer. So this is the big American College of Surgeons database looking at outcomes. And you can see by 2005, with H. pylori treatment and everything else, an awful lot of patients were getting, even with gastric ulcers, just local excision, with duodenal as well, many more than a definitive ulcer operation. And the only questionable data, there's not any that's very good, is this. Significantly lower mortality in patients who had some kind of definitive operation. Now it's not good enough data to make me say in the middle of the night in a hemodynamically unstable patient, you ought to put them through a bigger operation, but it is something to think about if you're familiar with these procedures and can do them. Perforated ulcer, there is good data that we don't need to do anything definitive. And so it's patch the ulcer. We typically talk about using omentum, not closing the ulcer, not closing the perforation, but just sewing the omentum to it. And usually not adding a vagotomy to that. Again, with gastric ulcer, because of the concern about malignancy, you either got to really biopsy it or consider a partial gastrectomy. We don't see these very often today, but obstructing, often duodenal ulcers are a tough problem to manage. I think it's very appropriate when these patients are present acutely to give them a period of NG2 decompression so that the stomach regains its tone. It's one of the biggest complications, that prolonged delayed emptying afterwards. A period of TPN with a PPI, correcting what are often significant electrolyte abnormalities. We do dilate some of these today. Our gastroenterologists will do that. The results are significantly better when it appears to be an acute ulcer. If it's chronic scarring, much higher chance of perforation. And then the procedures are vagotomy and drainage. If you can do a pyloroplasty, which is unusual, that is one option, but vagotomy and gastrojejunostomy, and vagotomy and antrectomy is kind of the fallback procedure. So subsequent management after both endoscopy and surgery, H. pylori biopsies or breath tests. If it's positive, treat for H. pylori. If you document cure, then you can stop PPIs. Do everything you can to reduce the use of nonsteroidals. If they have to be on them, the COX-2 selective are certainly better in long-term PPI. Patients that are on aspirin, if it's for primary prevention, they haven't had a cardiac event, discontinuing it is appropriate. If they've had a cardiac event, obviously, and they have a stent or need it, then continuing PPIs and the aspirin at 1 to 7 days. If you can't document a cause, then long-term PPIs are appropriate. So gastric cancer, I think a much more significant problem in Ukraine than it is in the US. It's still the 5th most common cancer worldwide, 1.1 million cases, 4th leading cancer cause of death worldwide, and high incidence and mortality rates in Eastern Asia, Central and Eastern Europe, Central and South America. So significant amount of progress has been made in staging, and we'll talk about that, and then in treatment based on stage. Localized tumor, which is about a quarter of what we see in the US, has a 5-year survival of 2/3. If they're spread to the nodes, then it falls to around a quarter. And then if they're distant metastasis, the 5-year survival is very low. Depending on where the tumor is, some portion of the stomach has to be resected. Increasingly, we are doing proximal gastrectomies. It used to be that the teaching was that the outcomes in terms of emptying were so poor with proximal gastrectomy and reconstruction by sewing the esophagus to the distal stomach that we couldn't be done. But with prokinetic agents and more experience, this is increasingly of interest and may have better outcomes in terms of nutrition than a total gastrectomy. So improvements we've seen in recent years have included improved staging and patient selection, which have helped identify patients for adjuvant therapy. We've figured out who needs and what sort of lymphadenectomy should be done, advances in surgical technique, and we're just starting to see the use of targeted therapies, monoclonal antibodies, which seem to be having an outcome, improvement in outcome. So early disease, up to T3 through the gastric wall is particularly when it's just T1 or T2, it's possible to do endoscopic mucosal resection with excellent results. Once it's T3 or in the nodes, and we'll talk about N1, N2, N3 in a second, there are good trials suggesting for gastric cancer, the MAGIC trial, and for GE junction, the CROSS trial, suggesting that neoadjuvant preoperative chemotherapy is of significant benefit. And then identifying distant disease and patients that should be considered only for palliative therapy is kind of where we are. So endoscopic ultrasound, kind of the cornerstone of identifying depth through the gastric wall and determining whether it's T1, T2, T3, 4. Good test with 80% accuracy, and we're using for these decisions about EMR versus proceeding with neoadjuvant and then subsequent surgery, and laparoscopic approaches to identify distant disease. After the patient has had a full staging workup, there's still a third of the patients that would be considered resectable who are found to have peritoneal metastases. So reasonable thing to do in everybody early on. And, you know, the peritoneal cytologies, you put in saline, take it out. Those patients with positive cytologies, what we're doing is really palliative treatment. So lymph node dissection. Up until not very long ago, most surgeons in the US were doing only D1 perigastric nodes based on what portion of the stomach they removed. D2 nodes, which we learned about primarily from the Japanese experience, but they're all these around the celiac trunk and its axes, or its tributaries. And there was controversy for quite some time about the benefits of taking all those nodes, whether it just added morbidity or not. D3 nodes, taken in some of the Japanese literature, we typically don't do that in the US. So this was the Dutch trial that really established the need for taking those D2 nodes off the celiac axis. Their initial report, there was no difference in outcomes, but with 15-year follow-up, the survival curves significantly diverged. So, and this trial suggested that splenectomy itself didn't add much, just increased morbidity. But we do recommend D2 nodes, more than 15 nodes is the value. D3, this was a randomized trial in Japan that showed no benefit. So D1 and D2, goal of examining 16 or greater lymph nodes is currently the US National Comprehensive Cancer Network recommendation. So endoscopic resection, we are doing increasingly for T1 and T2 tumors. Low morbidity, patients get out of the hospital quickly, they need close follow-up, etc. And this is kind of the algorithm. We look at the specimen. If it's greater than 2 centimeters, there's evidence of lymphovascular invasion, or they're undifferentiated, and we think they need additional treatment, gastrectomy and lymphadenectomy. Those are the rates of positive lymph nodes with those risk factors. For those no risk factor patients, there's a 5-year survival of 90 to 96%. And then just to briefly mention monoclonals, targeted therapies, emerging data that this is a benefit for locally advanced and even in the adjuvant setting for resected tumors in terms of improving survival. I think we'll see more and more of this as time goes on. So just relatively brief discussion of other gastric tumors. The stomach's the most common site for GIST. And we resect all lesions that are large, symptomatic. If they're metastatic, then we think about adjuvant therapy, i.e. Gleevec, before any attempt at surgery. But if there's no evidence, wedge, partial gastrectomy, etc. Small tumors, less than 2 centimeters, without worrisome sutures. There is a growing amount of data, and that means without a lot of mitoses, there's a growing amount of data for observation of those tumors if they grow larger than thinking about something else. The stomach is also the most common site of extranodal lymphoma. There are a group that are referred to as MALT lymphomas that are associated with H. pylori, and treating the H. pylori often makes the lymphoma go away. We treat those with RT if there's treatment failure. And then large B-cell lymphoma, CHOP chemotherapy, reserving surgery for complications today. The stomach's also a common site for carcinoids. Type 1 are associated with chronic atrophic gastritis. So there's no acid secretion, so the antrum makes huge amounts of gastrin, and that stimulates the mucosa and these carcinoids to grow. Taking them out of the proximal stomach endoscopically and then doing an antrectomy to eliminate the source of gastrin is the treatment. They can also be associated with gastrinoma, and there the management is really around trying to do something for the gastrinoma. Antrectomy, if it's unresectable gastrinoma, will have some, but not as much effect. And then the sporadics are the more aggressive carcinoids of the stomach and are treated with gastrectomy and lymph node resection. And finally, I'll just conclude, leave some time for questions with post-gastrectomy complications. So huge literature on this when we were doing a lot of surgery for ulcer disease, and patients lived a long time. In fact, we don't see many of these syndromes after surgery for gastric cancer, but they still happen. So duodenal stump leak when you've done a gastrojejunostomy, much feared complication. Think with closed suction drains around the duodenal stump when it's very friable. The outcomes of these are better than they ever have been, but they're still tough problems to deal with. Internal hernias behind the gastrojejunostomy, those have been a bigger problem with bariatric surgery, but we do still see those. The jejunum can intussuscept and cause obstruction or afferent limb obstruction into the gastrojejunostomy. Marginal ulcers at the gastrojejunostomy. And if you've taken on a lot of stomach, nutritional deficiencies are ones you really have to watch out for. Intrinsic factor is no longer there, etc. Remnant cancer is a significant entity, and patients who've had partial gastrectomies need long-term surveillance. So this afferent loop syndrome after a B2 gastrojejunostomy, postprandial epigastric pain that's relieved by bilious vomiting. For some reason, either the afferent loop is too long or partially obstructed. And the surgical treatment, if you don't have another option, is to convert it to a Roux-Y or sew the afferent to the efferent limb of the gastrojejunostomy, providing an outlet that doesn't include the stomach. That's called a Braun enteroenterostomy. Dumping syndrome, 2 phases. The first is thought to, well, they're both thought to be related to fast emptying of the stomach into the jejunum. Carbohydrates in a meal draw a lot of water in, and patients get weak and dizzy. You can also get hypoglycemic, kind of a rebound effect, and that's the late dumping. Octreotide is sometimes helpful in that circumstance, or conversion to a Roux-Y. Post-vagotomy diarrhea, significant in probably 5 to 10% of patients that have a vagotomy. Gets better with time. Nobody really understands why that occurs. It's definitely eliminated by that highly selective vagotomy, but is thought to be related to bile salts in the small bowel. Cholestyramine helps in some patients. I've never seen a reverse junal segment, but that was described. Alkaline reflux gastritis is very hard thing to diagnose, but does happen after B2 gastrectomies, sometimes after B1. Again, it's probably related to bile salts. Cholestyramine, PPI, sucralfate can all help with that. Conversion to a Roux-Y is the treatment. Surgical. Roux-Y stasis. Again, a very unusual problem. Prokinetics usually will work with that, as they do help with gastric stasis. And I think I'll stop there, leave some time for questions.
Yes. Thank you very much, Dr. Ashley, for your presentation. It was a very comprehensive topic to cover and very informative talk. We have already several hands raised, so please, Dr. Ismailov, your question.
Hello, thank you for the great lecture. My question is more of a, I wanted to know your opinion. So recently we had a case of total gastrectomy, which was complicated with periesophageal abscess, total gastrectomy with esophagojejunostomy. And the patient was complicated with periesophageal abscess, which was detected on day 7. My question is, could we have done something to detect it earlier, like post-operative day 1? Should have we done an X-ray with the contrast, or what? How? My question is how to be proactive not reactive.
Yeah, I
In
think
gastric surgery.
After a total gastrectomy, we typically do a gastrograph and swallow before we start POs. And that will detect some of them, but it doesn't show you all of them. I think it can be a very small leak, can be very hard to diagnose till the patient gets sick with them. We have had increasing success with stenting in some of these leaks. But if they have a big abscess, it's a reoperation.
Mhm. So, and was it day one X-ray with gastrographin, or day two?
No, usually day 2 or 3, when you're ready to think about, you know, we're using fewer and fewer NG tubes. It used to be when we were thinking about getting the NG tube, we put some contrast down, but now many of these patients aren't getting a tube. And I would say when you're about to start POs is when I'd consider it.
Thank you.
Thank you. The next question from Dr. Markia Nozdrin, please.
Thank you for the great lecture. Do you use routinely the antifungal treatment for the perforated ulcer? And what's your treatment choice for sealed perforations?
So we don't routinely use antifungal. We treat the broad spectrum antibiotics and usually anaerobic coverage as well. So a sealed perforation that you can demonstrate with a gastrograph and swallow in a stable patient, it's reasonable to observe.
Thank you. Dr. Sofia Lisecka, please, your question.
Good evening. Thank you so much for your time and great lecture. I want to ask you how many tries we can do to stop bleeding endoscopically before we decided to do the surgery. Like how many staplers we can do, or how long we can do coagulation for the patient.
So the typical recommendation is 2 endoscopic efforts. And at that point, either proceed with embolization or surgery.
It's like 2 divided, yes, procedures.
What's that?
2 divided procedures of
2
endoscopy,
separate.
yes.
So that you treat them once, stop, rebleed, endoscopy again. And if they rebleed again, that's when you need to move to something else.
And one more question. What is the best type of PPIs you use at the first 3 days after bleeding?
I don't think there's any evidence that one is better than another.
Because in Ukraine it's esomeprazole. Maybe I thought in USA it's also esomeprazole or something else.
Yeah, but I don't think there's any data that one is better than another.
Okay, thank you.
Thank you. And Dr. Alexander Boyarsky, please, your question.
Good evening. Thank you for the great lecture. And what could you recommend if the patient after gastrectomy has endoscopically purulent cover of the anastomotic area, but without evidence of leakage?
Like a fungal infection. I might try that. Diflucan. If I saw an exudate around the anastomosis and I was concerned that it was infective, that would be the thing that would cause that, is fungus.
Mm-hmm. Thank you.
Thank you. We have one more raised hand left. Dr. Ismail, or or it's left from the previous time?
Yeah, I actually had one more question. So there are a lot of there are two varieties of gastrectomy. I wanted to ask you, which one do you think is the best? Like with anti-colic gastrojejunectomy or retrocolic, does it even make a difference? Or should every surgeon just perfect one technique and use it like every time?
So I don't think there's ever been a good study comparing anticolic versus retrocolic. The traditional teaching was that for cancer, because of the chance of it recurring in the bed, that a retrocolic was not as good an idea, and that you should do it anticolic. The retrocolic, I think most of us think empties better, although I don't know any really good data that proves that. So traditionally for peptic ulcer, we did retrocolic and anticolic for gastric cancer.
Thank you.
Thank you. I think we have time for one more question. Please, Dr. Червоноченко.
Thank you for your lecture. My question is about proximal gastric resections. In terms of in terms of gastroesophageal reflux, did you experience some complications relating to that? Because I've listened to one lecture where it was discussed by a surgeon, and the surgeon said that in their department they totally stopped doing proximal resections for proximal lesions of the stomach because of reflux, and they proceeded only with gastrectomies. What could you say on that?
So when I was training, that was the teaching. But there's a growing experience in this country with proximal gastrectomy. You know, we've seen the proximal gastric cancers increase quite a lot in numbers, and people are having better outcomes than with total gastrectomy. There are reflux problems for sure, but usually treatable.
Thank you.
Thank you. And the last question from Dr. Kasan Ilkafarna, please.
Thank you for the great lecture. What do you think of the esophageal transection operation as a preventive measure for vaginal bleeding?
Well, I think it's one of those things that, if all else fails, has worked. It's been a very long time since I've heard of anybody doing that procedure, having that be necessary. TIPS has been so useful in controlling things.
Thank you. Thank you, everyone, for your great question and discussion. And I would like to thank Dr. Ashley once again for finding the time to share your experience with us and to contribution on today's topic. And would like to thank all of participants and encourage to join our HealUA application for your questions. Thank you all, and stay safe and enjoy your evening. Hope to see you on the next sessions.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you very much.
Thank you.